Hi, my name's Kai. I'm one of the FI1s currently working in Forth Valley Royal Hospital, which is a hospital in the west of Scotland. Thank you so much for letting us join your grassroots events and allowing us to present. Today, I would like to focus particularly on the ABCDE assessment. And the main reason why I would particularly like to talk about this is especially during your times as medical students or when you start to work as FY1, you'll realize that you'll quite often be asked to assess patients that you've never seen or met before. And this will be the kind of approach everyone uses within the hospital to allow you to use a systemic method to have a quick understanding of the situation and know where to start. So in terms of the content of today, I'll break down each section of ABCDE in closer details, and then we'll work through example scenario together with some question at the end if anyone has any other questions regarding today's presentation or in general, feel free to fire away. So first of all, in terms of A, we will be looking at the airway of the patient. What that means is simply just from walking into the room and starting a conversation with the patient, you'll know whether their airway is patent. So if they can speak in full sentences, and you'll know that there's no obstruction within their airway. Whereas if you hear some additional sounds or if you notice that they're struggling to complete their full sentence, then that might be a good indication where you have to assess their airway further. What that means is you'll be looking to have a look at the patient closely and listen to their airway. In terms of looking, there are some signs that you can look before you even go close to the patient. For example, the way they're breathing, if there's any increased work of breathing, are they using any abdominal muscles when they're breathing? And when you're looking into their mouth, if you can see any foreign body, blood, secretion, or any swelling that's obstructing their airway. Sometimes you may see cyanosis, but that is often a very late sign for hypoxia. In terms of sounds, some sounds that you might hear when the patient is breathing is stutter, which is a low pitch congestion within your nasal passage. And there's also stridor, it's a high pitched noise that indicates partial occlusion of your upper airway. And there's also wheezes, which would require a stethoscope for you to auscultate on the lungs to have a listen of the coarse sounds, which indicates the obstruction of your bronchi and your bronchioles. And there's also gurgling, which would indicate that there's fluid within the oropharynx. And for those situations, you might want to use suction and to help you to aspirate the content within the oropharynx to allow the patient to relieve their obstruction temporarily. And after that, you might want to look into calling for help if it's not resolved immediately, and consider the use of airway maneuvers and airway adjuncts to help to relieve the obstruction. Some maneuvers that we commonly use is head, tail, chin lift and jaw thrust. Head, tail, chin lift, as you can see on the picture on the right, is where you place one hand on the patient's forehead and the other one underneath their chin. By tilting their forehead back and lifting their chin forward, you can extend their neck, and that will help to lift the tongue away and help them to breathe. There's also jaw thrust, where you can put your index finger and your other fingers behind the angle of the mandible, and by lifting it up towards your palm, it will also help to open up the laryngeal inlet to help air into your lungs. If that doesn't resolve, then we have to think of using adjunct devices. And some that are commonly used are the oropharyngeal inlet, also known as the Goodell. There's different sizes to the oropharyngeal airway. We can see it's the device at the top, the red one. So there is a flange, and there's also the tip at the right-hand side. So the size is different for different patients, and how we determine the size is by placing the tip at the angle of the jaw, and the flange will hopefully be aligned with the center of your top teeth. And so there's different sizes, and by using this method, you can figure out the right size for each patient. The only issue with using the Goodell is sometimes for patients who are still conscious or semi-conscious, it can induce the gag reflex, which would be really poorly tolerated for them. In terms of how to use it, initially you aim to have the tip pointing upwards and insert it into the patient's mouth. And once it's inside the mouth, you rotate it 180 degrees so the tip is pointing downwards towards the feet. And you'll just keep advancing it until the adjunct lies within your pharynx. The other one we would like to use is the laryngeal nasopharyngeal airway, and that is by inserting it within the nasal passage and down into the pharynx. How we determine the size of that is by measuring the tip of the nasopharyngeal airway to the tragus of your ear, and the flange will hopefully align with the tip of your nose. The problem with this is that we normally would like to avoid using this in patients with a base of skull fracture. And some more advanced adjunct would be like a laryngeal mask airway, and which would allow you to slip a cuff into the right upon the larynx. And normally we'd like to use these in conjunction with your airway maneuvers. And hopefully at this point, you've been able to establish a safe airway for the patient, and also called for help to allow your senior and sometimes the more urgent, immediate emergency care adult team to come and help you. Then once we've reassessed the patient and ensured that a safe airway has been established, we would like to move on to breathing. And breathing, quite similarly, would include observations, and you would like to look, feel, and listen to the patient. So let's talk about the ranges in terms of the observations. Normally, we like to look at the respiratory rate, and a normal respiratory rate for a patient would be around 12 to 20. Tachypnea is where it's slightly high, and for those instances, we would like to think of differentials like asthma, pneumonia, COPD exacerbations, or even PE. And there's also bradypnea, where the respiratory rate is significantly slower. And for those who would like to think of causes, including sedation or opioid toxicity, or intracranial pathologies. The oxygen saturation we like to aim for healthy individuals is around 94 to 98, whereas for patients with COPD, we like to aim for 88 to 72, 88 to 92. Moving on to an inspection of the chest, normally have a good look at the chest to see if there's any injuries, scars, and deformities. We also like to just see if the patient's conscious level is still kind of alert, able to speak to you. And again, if there's any use of additional accessory muscles. In terms of feeling, some really useful things to look for is where the trachea is still central, and if the apex beat is deviated. Then you like to assess for whether there's echo expansion of the chest, and on percussion of the chest, you'll be able to kind of come up with further differentials depending on the sound of the chest, whether it's resonant, dull, or hyperresonant. Then listening would again include assessing the breathing sound and auscultate using your stethoscope. You may hear sounds including wheeze, crackles. Wheeze would make you think of asthma, COPD. Crackles, if it's coarse, you want to think of secretions including blood or infection and pulmonary edema, whereas some fine end respiratory crackles would make you want to think of pulmonary fibrosis. When there's no entry is where you start to get a bit worried. Could this be a pneumothorax or whether the patient is in respiratory arrest? So for these instances, you would like to make sure that the patient is still alert, conscious. If not, assess for the pulse. And if there's no pulse, not breathing, and they're not conscious, is when you like to call 22222 and start CPR and ask for the adult resuscitation team to come and assist you in assessing this patient. So in terms of the interventions we can do for breathing would be oxygen. There are different oxygen devices that we can use for patients. However, for people who are critically ill, we would like to start off with giving them a non-breather mask at 15-liter high flow. This is because hypoxia would kill you first before apnea. So I know we can be a bit cautious in terms of giving oxygen for patients with COPD, but for patients who are critically ill, we'll start with high flow and trying to wean them down as we assess them. There are other options, including the Venturi mask, which would give you a fixed flow rate depending on the different color of the Venturi mask you used. The important thing to know about these masks is that you don't try to turn off the flow rate. You will have to change the mask to ensure that you're giving the exact flow that you're requiring. Whereas if you try and turn down the oxygen for a mask like a 15% flow rate, it wouldn't be accurate after. So you have to move down to 10, 8, 4, 2, just according to the different flow rate that you're aiming for. And then there's also the nasal cannula, which is delivered from 1 to 4 liters. And that would just be a low to medium oxygen concentration delivery for patients requiring low oxygen support. And for breathing, the investigation we like to consider would be things including ABG or chest X-ray. C is where we move on to circulation. And again, we'll start off with observations and then look, feel, listen. So in terms of observations, useful indicators are heart rate and blood pressure. There's also the fluid balance chart, which would give you really useful information regarding whether the patient is overloaded or if they're dry. And the capillary refill time will indicate whether the patient has good perfusion throughout the body. So from looking at the patient, if they're gray, pale, and clammy, it will be a good indicator that they're currently not well perfused or there could be underlying infection. We can also assess for the temperature of the skin and also if are regular, what's the volume and what's the character. Having a look at their JVP is also a very good indicator of whether the patient is currently fluid overloaded or fluid depleted. And listening of the heart sound would give you an additional indicator in terms of whether the patient has any valvular diseases that you may need to consider in your different. The different types of intervention we'll do for patients at this stage is first, you need to ensure that you have IV access. This will help you in terms of gaining your further test for coming up with possible differentials to build down your differential diagnosis. And having IV access will also help in terms of giving the patient fluids and, for example, if they're in shock, you want to give them some fast fluid challenge. 500 be quite a normal volume for a patient who you're not too worried about, and you want to give them over 15 minutes. If you're worried that the patient might have some cardiac history and you don't want to be too aggressive, then you might want to start off with 250 milliliters first over 15 minutes, then reassess their blood pressure to decide whether you want to give them more or just stop there. Some other things you want to think of is cardiac monitoring, like an ECG. And if there's any signs of significant bleeding at this point, you want to consider calling 2222 and initiate the major hemorrhage protocol. It's also important to know that despite initiating the major hemorrhage protocol, if you're still worried about the patient at the time, you still have to put out another call to call for the adult resuscitation team so they know to come over to give you a hand. In terms of additional tests, blood standard ones would be full blood count using these CRP. And if you're thinking of sepsis, you might want to add in a lactate blood culture. If you're thinking that the patient is bleeding, you might want to think of cross-matching the patient or do a coagulation test. If you're thinking of differentials including like MI, then you might want to add in a troponin at this point or a D-dimer. And if you're thinking of the patient might have any drug toxicology that's causing their presentation like this, you may want to do a toxicology test at this point. Some other things you might want to consider for D is using AFPU or the GCS, which gives you a good indicator of what the patient's conscious level is like. Then you'll like to assess the pupils just to make sure that they're reactive to light and they're not constricted or dilated. A quick neurological examination will be really helpful as well. And don't forget about glucose. E would be everything else. So you want to know the patient's temperature to make sure that they're not pyrexial. This would be a good time for you to just do a head-to-toe check and including an abdominal examination. Look for any new rashes, any bleeding. And once you have stabilized the patient at this point, you can consider taking a full history, review their notes, their charts, the recent investigations, the medications they're on, and then come up with a SPAR for you to hand over to your senior or the relevant team. Do we have any questions at this point? If not, then we can walk through this case together. So you're during your night shift right now, you've been bleeped by one of the staff nurses who's increasingly concerned about a patient called Miss Hill. They're worried about him because he's been appearing very breathless and he is sweating profusely. In terms of Mr. Hill's background, when you asked a little bit more, is that he is a 17-year-old who initially admitted with a fall. He is waiting for a package of care, otherwise he's not really been requiring any medical review or any medical treatment throughout his stay. His past medical history include COPD, and he also has a background of hypertension and type 2 diabetes. So in terms of assessing this patient, now walking into the room, can everybody just contribute in terms of what you like to do right now? So we'll like to start with A to E. Say hi, yes. So we'd like to say hi to Mr. Hill. And unfortunately, he's very, very breathless and unable to respond to you as much. So given the fact that he's able to kind of breathe, and although he's unable to have a full conversation with you, his airway was still patent. And now we can move on to B. If we jump back to B, things that we like to think of is, so we can have a quick look at his observation chart, which his oxygen level right now is currently 80. So SpO2 of 80 on 2 liters of nasal cannula. And he's clearly quite breathless and using his accessory muscles to breathe. So his trachea is not deviated, and neither is his apex and cardiac apex. And on listening of the chest, we can hear that his right bass is quite coarse. There's some coarse crackles on auscultation of the right bass. And you can also hear that on percussion, and there's some dullness on the right bass as well. So at this point, I guess there are a few things that we've picked up on assessment of B that we would like to intervene on. So starting from the oxygen saturation of 80, despite Mr. Hill having a background history of COPD, an SpO2 of 80 is still severely hypoxia for him. So we would like to offer him some oxygen. In terms of the mask, like said earlier, for critical illnesses, we always like to start off with giving patients 15 liters of non-rebreather mask to ensure that we stabilizes their oxygen saturation first. And in terms of the examination, we can clearly hear that there's some coarse crackles, which would make us think of, is there any fluid? Is there any kind of infection going on? Along with the dullness on percussion, which would match with the differentials that we're currently heading towards. What sorts of investigation we might like to think of at this stage? So for chest, in terms of, for breathing right now, an ABG would be really useful in terms of giving us an immediate snapshot of the patient's current oxygen saturation. And also it would be really useful in telling us whether he retains carbon dioxide normally, and that will help us in terms of guiding his oxygen saturation later on the management plan. And a chest x-ray would give us imaging support in terms of our differential diagnosis. However, none of these will happen immediately. So once we're quite happy with the oxygen saturation and that we've stabilized in terms of his breathing, we can move on to C now. On assessment of his circulation, what are the things that we would like to consider? So in terms of circulation, some useful parameters we'd like to look at is his heart rate and his blood pressure. So Mr. Hill is very tachycardic with a heart rate of 110, and his blood pressure is sitting at 96/50, which is slightly on the lower side. On assessment, on assessment of his capillary refill time, it was 4 seconds, and on auscultation of his chest, there was no additional heart sounds, and you can hear S1 and S2 very clearly. And at this point, there are, again, some things that we picked up we can intervene on right now. For example, his heart rate and his blood pressure. clearly that he's quite hypotensive right now and he's having to work a little bit harder in terms of his heart rate, is a good indicator that Mr. Ho is currently quite fluid depleted. So it would be a good time for us right now to ensure that he has IV access and give him some fast bolus fluid, as we mentioned previously. And hopefully by giving him the 500 mils of fluid stat, it can help him to bounce his blood pressure back up to 110. Some investigation we would like to think of at this point. Does anyone have any idea what blood test you might want to do for Mr. Hill? FBCs and using these are always quite useful in terms of giving us a quite quick idea of whether there's any signs of infection. So if there's a raised white cell count, and then we'll like to do a CRP again, because again, it's a really useful indicator of whether there's any signs of infection. Hopefully not a D-dimer. I agree, because right now there's not a clear sign that there is that we are suspecting of a PE with his current presentation. However, if we are suspecting of PE, maybe he had some chest pain, or maybe we're finding some swelling of his calves, it will be a good time for us to consider D-dimer as well. And since we're thinking of infection and Mr. Hill actually does have a temperature of 30.1, so we also like to add in a blood culture as well. So now after correcting his C, we can see that his blood pressure is now back to 110/60. We're quite happy with that is responding to his fluid resuscitation initially, so we decided to give him another bag of 500 stat bag of fluid, and we'll move on to D. On assessment of Mr. Hill's awareness, we can see that he's currently alert. His pupil is equal and is reactive to light. Neurological examination wise, his forelimbs are moving fine, and his glucose level is currently 6.0. So for D, we're quite happy that there's nothing we have to work on right now. I'll move on to E. Like we've mentioned previously, he does have a temperature. So right now the story is fitting along with a differential diagnosis of a suspected infection, likely from a chest source. And on head-to-toe examination, you haven't noticed any additional bruises, rashes, or any sources of external bleeding. And his tummy is soft and is not tender to touch. And is there anything else that you would like to do for Mr. Howell at this point? So we're quite happy that from A to E, right now you've stabilized Mr. Hill, and it will be really useful now for you to think of, okay, now we're working towards a likely sepsis from a chest source. So sepsis 6, so far we have done oxygen and we've given him fluid. We've taken his blood and we'll probably add in a lactate as well. We'll have a look at his fluid chart to make sure that currently he's still passing urine, and we'll get accurate urine input and output from him. And we'll also want to start antibiotics pretty soon at this point. And yes, we'll probably want to inform the senior, and it would be either the medical reg or someone within your team that we would like to speak to and document what happened. speak to, we would normally like to use an SBAR format. What that means is we'll give the senior a good situation of what happened with a background of the patient, what assessment we've done so far, and what we think would be beneficial for the patient or what we would like in terms of their advice. And that would be us kind of finishing assessing Mr. Hill. Do you have any questions at this point? Okay. So we'll just quickly walk through A to E again. So like I've said previously, during OSCE scenarios or when you start working as an FY1, having to assess patients that you've never seen before is quite a common thing that you have to do. And a very useful systematic approach for us to do is by breaking it down to A to E. What that means is we'll first assess the airway, make sure that is patent, the patient can speak in full sentences with you, and that if not, you have to think of using airway maneuvers or other adjunct to help you maintain a safe airway. Then we would like to move on to breathing. And this is when you want to give the patient the oxygen that will require to give them to maintain a good oxygen saturation, and consider, for example, requesting for investigations like chest X-ray or ABG. And then in terms of circulation will be a good time for us to assess whether the patient require any additional fluids, and we'll like to do an ECG and additional blood test to help us narrow down the differential diagnosis further. Disability will cover everything else in terms of don't ever forget about glucose, and we'll like to make sure that the patient is neurologically still quite and grossly intact, and that their pupils are equal and reactive, and that they're currently alert. Everything else will just make sure that we've covered other sources, for example, a bleed that we might be missing, or if the patient has any other signs or symptoms that we're not missing or able to pick up from the beginning. And this will give us a really good approach in terms of establishing where to start where to assess the patient and where to move on from there. And we'll also gather good information in terms of passing it down to our senior in an SBAR format and allow further subsequent management for the patient. Do you have any questions in terms of A to E? If not, then that's my talk finished, and thank you so much for listening.